and I'm going to bring to you our first speaker, Annette Wundes, who is going to talk to us about multiple sclerosis. So this is a beautiful picture of Annette. She's an assistant professor of neurology here at the UW and also an adjunct professor at rehab. She's the co-director of UW Medicine Multiple Sclerosis Center, which is a huge center. The Northwest is one of the most dense areas for multiple sclerosis. We have more than our fair share. Obviously, she goes to beautiful places. You got your glacier there. She's interested in women's health issues that, for people that have MS and patient-reported outcomes. She uses a comprehensive care approach. She likes to differentiate multiple sclerosis from other conditions that mimic it, and believe me, there's a lot. She uses interdisciplinary symptom management. That means you have a bunch of different doctors who have different specialties come into the clinic and help manage the patient. And we should optimize disease-modifying therapies like I described for you for our artists. She earned her MD at Heinrich Heine University in Dusseldorf, which is her native country, and also trained in Brazil and Switzerland. She did a clinical fellowship here at the UW and then stayed. She's internationally known regarding her work in multiple sclerosis and is on the National MS Society Board of Trustees. Without much ado, Annette, please come join us.
Thank you so much, and that was a great presentation, Terry. I greatly enjoyed that, and I'd like to extend my good evening to you and my welcome to this session on multiple sclerosis. I would like to start us with asking all of you who of you know someone who has multiple sclerosis. I'd like to see a show of hands. And just like I envisioned, there are quite a few among you, and this is, as Terry said, the Pacific Northwest is an area where there are particularly many people with multiple sclerosis. The rate of MS is here higher than almost anywhere in the world. And I'd like to envision you for a moment in the shoes of somebody who's sitting in a physician's office, like the person you know, or maybe this person here on the slide, a virtual MS patient, and to sit in this office and being told that you have multiple sclerosis. Being an MS specialist, I can tell you that many, many questions come in that moment up. Questions of, why does it happen to me? What causes MS? What the heck is MS? And what happens with MS? And how does MS present over the years? People want to know how to deal with MS and how to treat MS. And it looks like that all the patients I talk to could be here in mini medical school because they are very research-driven, very interested to learn more than there is known at this point. I like to, during this presentation, I'd like to be guided by these questions and address those questions, but I'd like to start us off by kind of like getting over the basic facts. So basically, what's the MS 101? So MS is a chronic disease. MS is a disease which is a disease of the autoimmune system, or at least autoimmune modulated disease. It affects the central nervous system, which is compromised out of the brain, the spinal cord, and the optic nerves, which are actually an extension of the brain. We have around 400,000 people living with MS in the United States. Typically, MS is diagnosed when somebody's in their 20s, 30s, or 40s. But this is like a bell-shaped curve with very flat ends. So there are children which are diagnosed with MS, and some people are diagnosed with MS later in life. There's a strong predominance towards women. So for every man with MS, there are 3 women with MS. And Caucasians are more affected than other ethnic groups. But let me reassure you that in our clinics, we have many, many other ethnic groups represented: African Americans, Hispanics, Asians, to name some. One of the different things to deal with MS is that there's such a wide spectrum of presentations. That's obviously difficult for the patient themselves, to some degree, even for us as their providers. So on the one side of the spectrum, there are some patients who do fairly well and have only mild disease throughout their life. And then on the other side of the spectrum, you may have somebody with rapid progressive disease or who develops disability because of the condition. And what is the one thing we typically think of if we're thinking about multiple sclerosis? Many of us have this type of images in our mind. We're thinking about the neighbor or the teacher we had who had multiple sclerosis. It was very obvious because they walked around with a cane or needed a wheelchair. So is MS a disease of ambulation? That was actually how many people perceive MS, and that's also how we as a medical community thought about MS for many, many years. But let me reassure you that is very short-sighted. So if we have here a list of common MS symptoms, you will see a wide range of symptoms. Many of those basically depend on which part of the brain and the spinal cord is affected. And it may have, some of these symptoms on this list are physical symptoms, some of them are very obvious, and some of them are what we consider the hidden disabilities. So things which may not be notable to somebody around. So one thing, for instance, is fatigue. And when I'm saying fatigue, often patients describe this as either unpredictable or overwhelming sense of fatigue, which stops them from doing certain activities. Another thing on this list, which we consider the hidden disabilities, are difficulties with cognition. And frank dementia type of cognitive difficulties are extraordinarily rare in multiple sclerosis, but having some degree of cognitive difficulties in terms of slow thinking, having difficulties with being distractible, having some difficulties with multitasking are not that uncommon. And when I'm saying that, I think about myself, and many people in this room may think like, wow, I have that as well. And I think it's very important to think about, we all find us on this list on a bad day. We all may have had tingling or other symptoms, but they present differently if someone has multiple sclerosis, and we'll talk a little bit about this during today's presentation. Have you guys seen this billboard? It's an awareness campaign from the National MS Society, and I see two messages. First of all, they point out that the Pacific Northwest is an area with particularly high frequency of multiple sclerosis. But I also hear a second message, putting salt in our wound that 100 years of research have not identified a cause of multiple sclerosis. And I think at this point it's fair to say that's probably not a straightforward single thing, but instead a complex interaction of different things. There's a clear body of evidence that there's the genetic predisposition and component to that. We've known that for a long period of time, knowing by observation that somebody who has a first-degree relative with MS has a higher risk of MS. But with the advances in science and genetics and now the availability of genome-wide association studies, more than 50 genetic markers have been found for MS. Each single one, however, increasing the risk of MS only by a hair, just by an increment. So we've suspected for a long period of time that there must be additional environmental factors. And you can think about those as infectious agents and non-infectious agents. On the infectious side, very high on the list of suspects is Epstein-Barr virus. That's a virus which can cause mononucleosis. And this already shows you the difficulties we are facing finding a cause for multiple sclerosis. If we were to test everyone in this room for Epstein-Barr virus, 97% of us would show up positive. So how come that something is so frequent then causes MS in some of us? Living in the Pacific Northwest, you will be not surprised to hear that on the side of environmental risk factors, lack of sunshine, low vitamin D is pretty high. But you may be surprised that smoking also increases the risk of MS. In a way we don't really understand, these factors together then cause the abnormal immune response which we see in MS. And this abnormal immune response is targeted towards the brain and the spinal cord. I brought you here some images of MRI images of the brain and spinal cord. So this is how we look from inside. These images studies we use a lot for diagnosing somebody with MS as well as monitoring the course of disease. So these are both images as if I'm cut here in half like this and we're looking onto my ear. And it's always hard for me to say how that comes up on the screen. From here it looks like it may be, not too bad. So there are some white spots in here. If you don't see them, you surely will see the yellow arrows which point the right direction. And MS is by far not the only condition which can cause white spots on an MRI. There are many other conditions. In MS, they have a specific distribution, as pointed out on the slide. One of the specifics is that that MS causes also lesions on the spine, as seen here. Oops. In this area. And then we're using the MRI also to look for acute inflammation. So we'll give someone who's in the MRI scanner some contrast dye into their veins, and then if there's acute inflammation, the contrast dye leaks into the brain or spinal cord tissue and can be seen on an MRI image. So what do these lesions or foci consist of? What does that mean somebody has these spots on an MRI? So if we were to zoom in and look under a microscope, these are the things we would be finding. We would be finding inflammation, we would be finding something which we call demyelination and axonal loss, or loss of nerve fibers. Let me kind of talk about the last 2 points a little bit more in detail. So I blow up this middle picture and talk about demyelination for a second. So when MS was first described roughly 100 years ago, they did some autopsy studies and they found scar tissue on the brain. They found sclerosis. They found multiple areas of sclerosis, and they could see that in this area myelin is missing. And here you have a cartoon of a healthy looking nerve on the top and a nerve affected by MS on the bottom. So you have here the cell body here, and then there is the nerve fiber also called axons, and then you have here the synapses on this end. Basically the nerve cell talks to either another nerve cell or to some other tissue. And then you see this yellow bars here, that is the myelin. You can think about this a little bit like an electrical cord, where the electrical wire in the middle would be the nerve fiber, and the myelin would be the sheet around it. And the primary attack in MS seemed to be against this myelin. So as we see in the lower picture, the myelin is destroyed here, but we do need a healthy sheet of myelin for fast signal transport. So if the myelin is attacked and is structurally changed, then the signal transport is either slower or distorted. This was known for more than 100 years now, and that is often why MS is referred to technically as a CNS demyelinating disease. And it was very controversial for decades whether or not the electrical wire in the middle, the nerve fiber itself, is being affected as well or not. It took quite some advances in basic science to answer this question, and at this point it's pretty sure that roughly 10-15 years ago they were able to show that the nerve fiber itself is damaged in MS as well. And nowadays we know that the degree of disability somebody has with MS is actually more tied to the loss of nerve fiber than to the degree of demyelination. So here I'd like to describe, so now we know what's going on, but how does it look like? So I'd like to describe for you the typical clinical course the vast majority of people you know with MS may present. So we have here a time axis, and the first piece of data we're looking at are symptoms. I'd like to point out that this purposely does not have any scales, so it's meant to demonstrate the very mild case as well as a very severe case of MS. So at one day, patients will develop their first symptom ever. Typically, they develop over a day or two. Typically, they develop over a day or two, stay for several days, sometimes weeks, and then get better over time. In best case, full recovery. I really would like to have my pointer now. Okay, other hits. So best recovery, best case scenario, full recovery, and then they have may develop further relapses over time. I'd like to counterpoint that with MRI lesions. So each of these bars represents an MRI developing new spots or having acute inflammation. And I think if we compare these two pieces of data, two things become very obvious. First of all, there's much more MRI disease activity than clinical episodes, especially early on. And also that there's something like a subclinical stage. So before the patient develops their first symptom ever, they do have repeated episodes of MRI disease activity. If they then develop their first clinical episode, this goes currently by a very funny name, CIS, Clinical Isolated Syndrome, and this name is purposely different from MS because there are some people who have one episode throughout their whole life and don't develop new disease activity. But if they do, then they enter the stage of what we call relapsing remitting MS, and different people have different clinical presentation, but basically they will have various severity and frequency of these relapses. I've again lost my pointer here. Different severity and relapses over time. They may have improvement, but they may not have full recovery. Typically over time, there's less and less good recovery with these episodes, so that people develop a stepwise accumulation of new symptoms. Some of patients then transition later to what we call secondary progressive MS. And the key feature is here, let me see if I get the pointer out again, that patients develop new symptoms in between relapses. So the bar is increasing in the absence of a relapse, whereas the bar was pretty steady before the relapses and the relapsing remitting phase. So we already learned that there are different types of MS, and the main type is relapsing remitting MS, as we have seen here described in greater detail on the previous slide, presenting roughly 80 to 90% of all people with multiple sclerosis. Those then may transition into what is called secondary progressive MS as a later stage. And then the third main type is called primary progressive MS, and here people do not have relapses, but have from the start gradual worsening over time. This is represents roughly 10% of all people with multiple sclerosis. There are some specifics for this type. Here actually it's equally affecting men and women, and typically presents a little bit later in life. So now we learned what MS looks like, but the overall question is obviously what can we do about MS? And I'm very pleased to report to you that it's no longer what was mockingly often referred to as diagnose and adios, because we didn't have anything to offer to our patients with MS. Nowadays, comprehensive MS care includes several things which are very important and listed here: controlling the disease, helping with symptoms, and guiding towards favorable lifestyle choices and consideration of complementary alternative treatments to help with well-being and function. And I will, in the next slides, go over these achievements which have been done and how the face of MS has changed with these treatments. So controlling this disease, the technical term that is being done by medications which are technically referred to as disease-modifying therapies. Casually, we call them MS drugs. And all these drugs have demonstrated that they reduce the rate of relapses, that they reduce the severity of relapses, that they reduce MRI disease progression, and that they also can reduce the risk for developing definite MS in people who are at risk for MS. On this slide, I'd like to show you from basically where we are coming from and where we are now today. So I will review you the breakthroughs we have seen in MS treatments, and I will divide this available treatment options into what we consider first-line agents and second-line agents. A first-line agent is a medication we would consider in somebody who's newly diagnosed or has never been on a treatment before, whereas the second-line agents we may consider if somebody has previously on a drug but it didn't really work for them. It may have not worked because they couldn't tolerate it, or it may have not worked for them because it didn't control their disease. The first drug ever available came out in 1993. So until 1993, which feels for me like yesterday, nothing was available. There was nothing which we could offer to alter the course of disease. In 1993, the first drug called betaseron came out, and originally there was such a short supply that it was actually given by lottery, who could go on these drugs and who couldn't. That has pleasingly quickly resolved, supply improved, and other drugs of the same class became available as listed here, as well as Copaxone. These drugs you find here, that's drugs which are commonly used and we consider our first generation medications. And as all the other drugs I will introduce you to, they all come with their pros and cons. Here the pro is clearly that they have an excellent safety profile. However, they all are self-injectable medications, so where people have to give them self-injections as much as once daily. In 2000, a chemotherapy called Noventron was approved, was given every few months. Nowadays, we rarely ever use this drug anymore because it is associated with long-term safety risk, has been found to cause leukemia and heart failure. In 2006, another breakthrough came in a medication which we now use quite a bit. It's called Tysabri. It's also being given as infusion, typically quite effective and typically well tolerated, but it also comes with a safety risk. It comes with a rare risk of a brain infection, which can be actually fatal. And we nowadays have some blood studies where we can look for an individual person what their risk towards this brain infection is, and can take this into our decision making whether or not to consider this drug. In 2010, there was another breakthrough because the first pill was approved for MS. It's called Gilenya, and it's approved as a first-line agent in the United States, but only as a second-line agent in Canada and Europe because it's associated with some safety issues, primarily risk of infection and some cardiac side effects. Late 2012, another pill was approved, and we anticipate that the FDA will approve in March, so next month, yet another pill for MS, which a much more favorable safety profile. So if you look at this graph, you see that there was nothing available since 1993, and nowadays we are faced with having so many choices, and now the challenge is actually what is the right drug for an individual person. And using these drugs, we have some lessons learned. The first lesson learned is the benefit of early treatment, which is at this time no longer controversial. So some patients you may know may have never had the benefit to be on these treatments because they were either not invented when they were diagnosed, or we didn't really understand on how using these drugs in people who have MS at that point. We have also learned that not every type of MS responds to these treatments. Most responsive is relapsing remitting MS, and as of yet, we unfortunately have nothing to offer, no FDA-approved treatment to offer for our patients with primary progressive MS. There are two huge, large international trials going on now for patients for primary progressive MS, and I hope that this will change in the near future. But beyond the MS type, we also have learned that it's not one size fits all. We need to consider the individual characteristics of someone's disease, whether mild or severe, the prognostic factors. Especially with the newer drugs, we have to think about what other medical conditions or treatments they are on. And then it comes very important also in this decision making is patient preferences. Considering the risks of the drug versus the risk of not sufficiently controlled MS, considering certain side effects or route of administration, needles, infusion, or a pill. So it's a very individual decision to make with many factors to consider. The next thing I'd like to talk about is symptom management, and even though I don't have a slide which illustrates that nicely, we have also made major breakthrough in terms of symptom management, even realizing that how important this is, and we need to put this on our agenda. And symptoms are typically treated with either behavioral strategies, non-pharmaceutical strategies, or medication, often enough a combination of several of these approaches. And I picked one example, and I picked fatigue, and I didn't pick fatigue randomly. I picked fatigue because fatigue is the most common MS symptoms. 75% of patients report fatigue, and half of them tell us that it's the single most disabling symptom. So this would be one way of dealing with fatigue. It's actually it's not completely out of what we actually do, but we still prefer prefer MS patients to consider this as a baseline, getting good night's sleep and regular exercise. We then may have to consider a whole slew of other things. We have to think about other medical conditions. Example would be sending someone for a sleep study to check if they have sleep apnea and if present, treated. We may have to take very good care of screening and if present, treating depression. Depression is quite common in patients who have MS, as well as you may know that depression itself can come with this overwhelming sense of fatigue. We have to critically review their medications. We may have started medications in good intentions, but they may cause or contribute to fatigue. So we may have to reduce, tweak, or discontinue certain medications to help the patient. We may have to look very closely if there are any MS symptoms which interfere with their sleep. Example would be somebody has to go every hour to the bathroom. They obviously don't get a good night's sleep, or if they are that they are awakened by painful cramps. Then we may have to think about energy conservation strategies. That may mean very different things in different folks. For some people that may mean pacing themselves. For other people it may mean actually taking a nap and recharge their batteries. And then it may mean for some people to use actually an ambulatory device, even though they may not feel it's really needed at this point. But if that helps them to go from A to B, and they still have energy left and don't spend all the energies between these 2 points, but then once they're at B, then have energy left to do some meaningful activities for them, that's a way of thinking about energy conservation. Many folks with MS may have what we call heat sensitivity, and the most common presentation is that they have an overwhelming sense of fatigue when they're exposed to heat. So we may have to think about how to keep them cool and how to avoid that. With all that in mind, we still may think about medications, and I'd like to point out that there's not a single FDA-approved medication for MS, but we are borrowing from other indications. The list here you see are common medications which are used for MS. There's, for instance, amantadine, an antiviral with a mild effect. And then we may be borrowing medication which otherwise are being used for sleep apnea, for ADHD, or we may put somebody on an SSRI antidepressant, even though they don't have depression, just to help with their MS fatigue. The last thing I'd like to talk about where we made progress is understanding better the importance of lifestyle choices and complementary alternative medicines. And we learned already earlier that smoking increases the risk of MS. What we have also learned in studies is that MS patients who are smoking are worse off than patients who are not smoking in terms of their MS severity. We know that pain, depression, and stress is the enemy of MS. And there are obviously lifestyle choices which can promote stress levels. And then there are lifestyle choices which can have a favorable effect on stressors. Regular exercise undoubtedly is good for everyone. For us, that was actually quite controversial. And in the past, MS patients were cautioned against exercise, but it's just the contrary. So the concern previously was that they get hot, that they may have worsening of their symptoms when they exercise. But we have learned that regular exercise, MS patients have better physical function, better cognitive function, as well as better emotional well-being. Undoubtedly, healthy, balanced diet also important for everyone in this room. However, it may have particular additional benefits for someone with MS. Let's think about healthy weight. Somebody who weighs 170 pounds or 230 pounds and has some weakness in their legs will have obviously a different way of help with their strength to move around. If they are not that heavy, they will have a better functional status with the same amount of strength. Also, a healthy diet helps against constipation. Not having constipation helps with good bladder control. Some of my patients come with long list of supplements. Several supplements promote to be good in MS. Not all of them are actually studied. The ones which are studied and have shown a favorable benefit are listed here, are the vitamin D, the fish oil, and the antioxidants. And then, depending on your definition of complementary alternative medicines, there are certain parts listed here, which for me almost, at least living in Seattle, feels like midstream lifestyle choices: yoga, acupuncture, massage therapy, meditation, relaxation techniques. All of that helps with dealing with MS symptoms and improves quality of life and function. So the last question this person posed to us in the beginning was where research is going, and I leave you with a slide in identifying the main areas of research at this point. When I go to one of these national conferences for neurologists, I always are faced with the envy of other neurologists working in different fields about how much research is going on in the area of MS. I'm not sorry to say that is so, but there's a lot of research going on the basic research on the mechanisms on MS. An area which was previously neglected is learning more about progressive MS, but this has become much more attention over the last few years. There's a lot of research going on better understanding repair and regeneration. Obviously, that would be a major breakthrough for us if we could offer this in a pill. There's a lot of research going on the role in vitamin D, and ultimately we want to have even better effective and better tolerated medications. So with that, I thank for your attention. I leave you with a picture of our team, and I'm not sure how well that comes out, but we all have a nice mustache on there. And so this, we are wrapping up for the MS walk, and our theme this year is mustache. And I invite you all to join our team. Any questions?
What would be the definite diagnostic test for MS?
Sorry, I didn't understand this exactly.
The diagnostic test for MS. Obviously, you cannot diagnose MS by symptoms, right? So it should be some test.
It's a combination of history, physical exam, where we anticipate to see some neurological symptoms, as well as MRI studies. And then worsening of the MRI over time may contribute to a diagnosis, so a single MRI sometimes does not answer the question clearly. And then there are additional tests which we can do. Lumbar puncture is sometimes being done. Then we'll do some electrodiagnostic, and where we can see the effect on MS on the signal transport, on the speed of the signal transport.
Thank you.
to this, can I ask, it used to be they said there was no definitive diagnosis for MS. I haven't kept up with MS, but it sounds from the answer, like from the answer to her question, that there still is no definitive diagnosis for MS. Is that the case?
Depends a little bit on how definite you mean. So sometimes I say jokingly, the only definite answer we get on autopsy, but that's a test we rather don't like to do. And so other tests shy of that will give us the indication and likelihood of having MS. But we don't typically do biopsies unless it's something which looks like it's a tumor, and then we'll find out and actually it is MS instead. So the definite diagnosis would be biopsy, but we rarely ever do that.
Yeah, I was wondering if in the early stages of the disease, when you were showing the chart, how there was a lot of, it seemed like nerve damage, and then there would be a symptomatic episode, and then it seemed like as the person had more symptoms, it was almost like the nerve damage, or at least the nerve attacks, waned a bit. I read about the fact that sometimes when people have like brain injury, how their nerve passageways can kind of compensate for the fact that some areas are unavailable. Is that one of the reasons why there is more activity but less symptoms, whereas as it gets later when there might be more damage to the nerves, that the symptoms just keep getting worse and worse?
That's exactly the case. So our brains are smart. They are rerouting information. If there's basically a roadblock of one of these spots, the nerve fibers around take up the job and kind of do the same thing. And the patient may not notice anything that this is happening. This is why it can be that so many times there can be people having quite a lot of nerve damage before they even notice the very first symptoms because of the rerouting of information.
Wow, that was fabulous. That was just fabulous, wasn't it?